All right, Doc, so let's discuss a proper workup of a foot and ankle exam. So when I start the workup on a patient with one of these, I always look at foot posture first. So every new patient that comes in my office, we put them on the Foot Levelers kiosk, a digital foot scan. Feet are the foundation, so you want to get a good image of what is going on there foundationally. That scan will show you what their level of pronation is. It will show you how they bear weight side to side, and it'll show you if there's any difference in arch height from left to right. If you don't have a scanner, I've already talked about this in other modules before, but what you want to do is look for the 5 red flags of pronation. So I'll quickly review those with you. Noah, will you stand and face that way just for a minute? So the 5 red flags that you want to look for are, when you look at them from the back, you want to look to this, say, do they have medial bowed Achilles tendons? Okay, so you look for that. If they have medial bowed Achilles tendon, that is a classic earmark or sign of excessive pronation. Always put a finger or two underneath the medial arch, and if you can't get it under there very far, that is a strong indicator of excessive pronation. Turn this foot out now a little bit, and that one. You watch them walk and they exhibit that external foot flare, that is a strong indicator of pronation. The other thing is, the external foot flare patient usually then will have concurrently internally rotated knee. So if you would draw a plumb line down from the middle patella down, it should intersect with the first toe or the second toe. But if it falls inside of that line, that is a classic example. So they have a medial rotated knee, they have an externally rotated foot, okay? And then the final thing is, you can have a seat on. Look at their shoes. If you look on the back corner of their heels, usually the pronated foot patient will have lateral heel wear, and it's usually asymmetrical. So you get those shoes off, you look at those heels, you look at the scuff marks and the wear patterns, and you'll see that lateral heel wear. Those are the 5 red flags of pronation. All right, so watch them stand, look at their posture, look for those 5 red flags, watch them walk a little bit, and if you don't do that, at least get that scan done. Those are kind of the essential things when you're looking at overall foot posture. Noah, will you lay on your back here? So now we're just going to demonstrate some of the supine exam procedures. Remember, with exams, docs, you always want to do it in order of position. So do your standing test first, then I usually go to supine, and then we'll finish up with a prone test or two. So from a good clinical workup with the feet and ankles, you just, you want to screen range of motion first. So I always compare left to right in most, or if it's just, one ankle injury or one foot, look at that motion. But it's good to screen them both. So your 4 main movements of the ankle: Noah, bend your ankles up far as you can. Of course, dorsiflexion, bend them down far as you can. Plantar, bend them in as far as you can. Inversion and out. Okay, eversion. Actively, and then take them through those same motions passively. And you're looking for motion restrictions, pain. If they have limited motion and pain with active, then you're thinking it's more muscle, tendon involvement. If they have pain with passive motion, then you're thinking more ligamentous involvement. I always do, right after I do my motion checks, I do some resistant muscle testing. So for the foot and ankle, I like to check the peroneals and the tibials anterior and posterior. So no, let your ankle come up and out. Hold it there. Don't let me push it down in and resist me. Boom. Peroneus longus, or peroneus brevis. And then we would go, let it go down now and out. Hold it there. Don't let me push it up and in. Resist. There we have peroneus longus. And then let it go up and in, hold it there. Don't let me push it down and out. Resist, good. Tibialis anterior, and then down and out, or in. Hold it there, don't let me push it up and out. Resist, good. Tibialis posterior. No, push your foot into my hand. There we got the gastroc and soleus. So that covers most of your muscles of the lower extremity, and you're going to screen a lot of times if they have some type of a tendinitis type thing, Achilles, peroneal tendinitis, posterior tibial tendinitis where it hooks down into the navicular area here will help screen some of those foot and ankle tendinosis type conditions. Then I would usually go into some specific orthopedic tests. For ankle injuries, generally you're looking at an anterior drawer test. So that one you would stabilize with one hand above the ankle joint, grasping the bottom of the foot on the other, or you can grasp around the ankle or top of the foot here. But at either rate, stabilizing and you're gliding that ankle forward like that. It's kind of like anterior drawer of the knee, but we're doing of the ankle. And you're looking for pain or ligamentous laxity there, which is going to be indicative of the grade of sprain of the anterior talofibular ligament, which is the most commonly sprained ligament in the human body, by the way. That's a test you definitely want to compare left to right. If they have say they have a right ankle sprain and you're looking for laxity, you sense it or you think you feel it, you want to compare it to the other side, the non-injured side, to see if that is an issue or not. The test that I use, if the person comes in with pain more towards the ball of foot area or the distal half of the top of the foot, you're usually looking at one of two conditions there. You're looking for a condition called metatarsalgia or interdigital neuroma. And so for that, you want to do a test it's called 4-foot compression test, where you take equal amounts of pressure on the outer side of the foot, just right at about the metatarsal head area of the little toe and big toe, and I lift the foot off and I provide equal pressure squeezing in. And if they get any reproduction of pain into that ball of foot shooting into the toe or through the dorsum of the foot, it's a pretty strong indicator of metatarsalgia or interdigital neuroma. The other test that I go to from there is one called Strunsky sign. And what I do with that one is I will grasp the toes, especially the last 4. I'll curl my hand over it to get under the metatarsal heads, and then I will plantar flex the toes while I'm providing pressure up into the ball of the foot. If that reproduces their pain, that's usually a strong indicator of metatarsalgia. Okay? So 4-foot compression, also sometimes known as Morton's test, and Strunsky sign are really good tests to do. Some people, a good screening test to do for lower extremity, because sometimes you'll get these people with calf pain that come in, and sometimes you're wondering, is this a calf strain or is this a blood clot? Is it a DVT, a thrombophlebitis? And so I a lot of times will do what's called Homan's test, where we'll lift the leg about 45 degrees, I'll palpate the area of the calf where that pain might be, and then I will sharply dorsiflex the ankle like that 2 or 3 times. If they get pain that quickly goes away, that's a pretty strong indicator of a DVT. If they have pain and it's like, oh, it just lingers on after that, then you're thinking more it's a calf strain situation, like a pulled calf muscle. The other test to rule out nerve problems in the foot or ankle, a lot of people get a condition called tarsal tunnel syndrome. It's the lower extremity equivalent of carpal tunnel syndrome at the wrist. This happens right at the medial ankle, just below the medial malleolus, slightly posterior to it. There's an area where the posterior tibial nerve comes through where they can get tarsal tunnel syndrome. In that case, you grab your reflex hammer, or you can use your fingers, but the bottom line is, I usually use a reflex hammer and I'll tap right into that area. Not super hard. In fact, let me grab my reflex hammer here and I will quickly demonstrate. I like these reflex hammers, Doc, that have these long handles, not those old dinky ones they showed us in chiropractic college, because these you can get a good whip on them. And so we will tap right over that tarsal tunnel area, and what you're looking for is not just some localized little sensation. You're looking for a reproduction of symptoms either radiating into the bottom of the foot or down into the toes. And that will pretty quickly tell you if they have tarsal tunnel syndrome or not. Especially when we're working up our neuropathy cases, docs, that is an important test to do, because sometimes they'll have compressive neuropathy, and tarsal tunnel is one of those. The other area you want to always check too, docs, if they have tingling or numbness into their foot, is to make sure you palpate behind the fibular head for peroneal nerve entrapment. So find that top of that fibular head right behind the knee, deep palpate in there, and usually you'll find this taut, tender, really trigger point area that the patient usually will give you the jump sign when you find it, if it's a problem area. And a lot of times when you rub over that and put pressure, so when you rub on that area behind the fibular head and put pressure on that, a lot of times you will be able to reproduce their symptoms. They'll say, oh doc, that's it. That's the symptoms I sometimes feel down my leg. The other area where that nerve will get entrapped is coming from behind the fibular head, going to the fibular head on the lateral side, then going down about an inch, maybe 2, right below the bony knob. You feel the fibular head. That nerve will come from behind and then it'll go down. So a lot of times right where it crosses at the fibular, below the fibular head, right in here, there'll just be this exquisitely tender area, and you'll push into that and like, whoa, you'll get the jump sign again, and then you hold pressure there, and sometimes you'll find that it reproduces their leg symptoms. So you have 3 areas of compression in the lower extremity. You have between the metatarsals, so you can get interdigital neuroma of the plantar nerve. You can get tarsal tunnel of the posterior tibial nerve at the medial ankle, and then you can get entrapment of the peroneal nerve behind the fibular head or just on the lateral side of it. All 3 of those can cause tingling, numbness, neuropathy type symptoms into the foot. So those are the main orthopedic range of motion tests that I do from a supine position. There's really only, and then the final things you'd work towards with this is just palpation. If they're a plantar fasciitis case, obviously you're going to palpate the plantar surface of the foot, the heel, the soleus, the gastroc. If they have lateral foot pain, you definitely would want to palpate the peroneals and the lateral foot. If they have medial foot pain, then you want to palpate the tibialis posterior area and some of the medial musculature of the foot. Chiropractors are the best palpators out there, so use your palpation skills to identify areas that could be contributing to the patient's symptoms. Then I usually finish up the exam with the patient moving prone. No, will you lay on your tummy, please? There's a simple test that you can do from this position called Hoffa's sign or Hoffa's test. Say you're suspicious that the person has a ruptured Achilles. You a lot of times will just see that the side of involvement of that, the ankle, the foot is much more in a dorsiflex position than the non-involved side. And another test you can do to see if it's a calf strain or it's an Achilles injury is just simply to squeeze the calf. And you should get a gentle nodding or a plantar flexion of the ankle with that. And that means the Achilles tendon usually is intact. If you do that and there's no movement, it's a pretty strong indicator that the Achilles is not intact. And then finally, some cases of foot and ankle injuries need x-rays. So standard views are the AP, medial oblique, and the lateral ankle, and same with the foot. The AP foot, the medial oblique foot, and the lateral foot. If you are working up a plantar fasciitis case and it's one of your niche patients, I recommend, or if you're doing laser or shockwave or any type of foot or ankle condition you're treating, it's a good idea to do a lower extremity index on them at the beginning of treatment and at the end, and to track your clinical results. Especially if you're niching neuropathy or plantar fasciitis, keep track of your stats so you can tell patients the next year what you accomplished with that particular niche in the previous year, and it'll give you more clinical confidence, and it will give the patient an idea what to expect. Their odds are of success from your treatment. That, my friends, is a pretty thorough foot and ankle exam. Hope this helps.